So our next speaker, Andrej Spec, who is associate professor at WashU, Division of Infectious Diseases, and he's going to give us, I think by necessity, a fly-through review of the 15 new they're not 15, but there are a lot of new antifungals, and Andrej is poised to give us a review of these compounds that are in development, not yet approved, but most of these are well into clinical trials, with a couple of exceptions. Thank you, Andrej.
Thank you all for inviting me. I just wanted to let you know I am going to cut back on some of these because of time. Otherwise, I'd be doing about 30 seconds per compound and not doing any of them justice. So I'm going to be focusing more on the ones that are getting closer to actually being used in patients outside of trials. So, but if you do want to get a good handle on all of them, I would suggest checking out our review, which kind of has the same title from OFID, which we published, I think, in early 2020, which now feels like 25 years ago. So we're going to talk real quickly about why do we need new antifungals, and this is a topic that's going to be not surprising to anybody in this group, which is the mortality is a few things, but one of them is that the mortality is still very, very high in fungal diseases and really doesn't appear to be going down all that much. There's also a current deficit of a historic low rate of drug development, and in the 21st century, so this century, we have one new novel class of antifungals, which was the echinocandins, which were approved in 2001. As of now, 20 years ago, was the last novel class. Then we got echinocandin number 2, echinocandin number 3, which are effectively the same drug. 2 new azoles, which the big addition there was oral treatment of mucormycosis. But in reality, it's another azole, a drug class that we have had for decades. And we've had 3 new formulations of azoles, but again, these are, while welcome and appreciated, are also just drugs that we've already had. So what does this leave us with in the landscape of treating invasive fungal diseases? And it's 3 classes of antifungals that are really doing the bulk of the work. We sometimes use terbinafine and a few others, but in reality, it's 3 classes. They only target 2 pathways. Only 1 class is oral and 1 is highly toxic. And the oral one is still pretty toxic and has lots of drug interactions. So the deficits that we have also are intrinsic resistance. So there's a lot of fungi out there that do not have any PO options, things like Candida, many of glabrata and Ceoris isolates. Azole-resistant aspergillus really ends up with IV-only therapy, which is really terrible because you're treating these patients for months and sometimes even years. Intrinsic resistance to all antifungals is present in isolates of many fungi, like Scopulariopsis or Lamentospora. There's also growing resistance around the world with the emergence of Ceoris. There's been some really wonderful data from Duke showing the rise of echinocandin resistance, as well as the rise of azole resistance, more prominently in Europe, which appears to be associated with agricultural azole use or azole-like compound use. So the good thing about this is that we do have a pipeline. And this is the most robust the pipeline has ever looked. And this slide at this point is a little bit old, and we have a few things that have progressed past where we have them on this in this image. But the sheer number of compounds that we see on this image is really what's exciting. And again, I'm gonna focus more on the ones that are up top and closer to the development. But if you do want to see them all, again, our review is quite exhaustive. So cell wall active agents. So we have rezafungin, brexafungin, and fosmanogepix. Rezafungin is our newest echinocandin that is in development. It's a derivative of anidulafungin. It has increased stability, which may lead to less hepatotoxicity, possibly. We haven't seen the phase 3 data yet, although the phase 3 has completed enrollment, and we should be expecting that data pretty soon. But the real benefit of rezafungin is that we have actually a much longer, much more stable compound. And so the dosing becomes once a week. So instead of having to do daily dosing, we have once a week dosing. It achieves very high levels. You can see here in the PK data on the right. It doesn't appear to have the same paradoxical reactions as caspofungin, so that's good because even given the levels that we're achieving. And it's active against most echinocandin-resistant isolates, and it appears to overcome the resistance largely through just brute PK force. And this does include things like Candida auris, which is the one that we worry about the most long-term, probably. Ibrexafungerp is another compound that has actually recently gained approval for non-systemic disease. So this is an oral beta-glucan synthase inhibitor. It's not an echinocandin, but the way it's often described is an oral echinocandin because it targets the same protein as the echinocandins do. And so it is often called an oral echinocandin, but you can see the chemical structure is completely different. It has broad activity, very similar to echinocandins. It's active against echinocandin-resistant Candida. And IV formulation at this point doesn't appear to be likely to be marketed anytime soon, so it is an oral-only compound. It's active against Candida, Aspergillus, PJP, dimorphic molds. Those two more in vitro. We don't have a lot of clinical data on that yet, and as well as things like L. prolificans. It has a very high volume of distribution and high tissue penetration, so that's great. It concentrates inside of acidic tissues, which makes it helpful for things like vaginal secretions, which are pretty acidic, as well as abscesses. So a lot of us are really excited to see what's going to happen when we start giving ibrexafungerp to intra-abdominal abscesses, which are highly acidic and would lead to trapping the molecule and actually high rate of very high PK in those abscesses. It doesn't have any penetration to the brain or eye, so that's an important limitation to know about it. And its current areas of study are in invasive candidiasis and is add-on therapy for aspergillosis, kind of following the MAR 2015 study, as kind of trying to look for improvement in invasive aspergillosis. And in VVC, it was approved already in 2021 under the name Brexafem. But be really careful of dosing. Just because it's available on the market right now for VVC, doesn't mean that we'll be able to use it off-label for invasive disease, because we really don't have the data for that. And the dosing is so different that you'd basically have to be opening a whole package every single day to dose the patients. That would be very difficult. The other, so likely future roles is probably going to be involved in step-down therapy, especially in resistant isolates, and possibly azole synergy in aspergillosis, or maybe treatment of a few of the other more rarer things we see. Fosmanogepix. Now, this is the first one that we're mentioning today that actually has a novel target. So unlike the last two, which we talked about, which attack the beta-glucan synthase, this one attacks GWT1. So it's an inhibitor of GWT1, which is a GPI anchor protein synthesis protein. It unmasks fungal cells to the immune system is one of the mechanisms of action. It also destabilizes the fungal cell wall. And it makes it more difficult for it to attach and invade tissue. So it's actually kind of working at both a site of stability, a site of protection from the immune system, and a kind of a virulence factor. It appears to be pretty low toxicity because it has no activity against the closest human analog, which is PIGW. It's both PO and IV. This is the compound that was earlier on was mentioned to have been bought out by Pfizer. So Amplix was bought out by Pfizer. As a result, it's now entering phase 3 trials. It has a bunch of orphan drug statuses. And it has some really nice, interesting properties. One, it's got greater than 90% bioavailability. It's pretty broad spectrum. It attacks Candida, Crypto, Cocci, Aspergillus, Fusarium, Euchorales, Limitospora. It lacks activity against C. cruzii. So this is a really important compound. It does not have any activity against cruzii. It is active against fluconazole and concandida-resistant isolates. It has extensive tissue distribution, and most importantly, it does get into the brain and eye. So this could be our future oral compound for use of things like endophthalmitis with fluke-resistant strain, things like that. And it eventually is excreted through the biliary tree. Future roles, broad antifungal use, trials ongoing. And then next we have cell membrane active agents, which I'm literally just going to go very quickly through because they're relatively early on, and I really don't want to go too far into them. So the first one is azoles. You know, we know azoles. We all love azoles. They're our workhorses. They're kind of the thing that we probably prescribe the most. I think the azoles at this point are about 70% of my prescriptions. And so the next generation azoles, which are made by Biomed, which has now been bought out, are really interesting. And I'm not going to belabor their point, going too much into them because they are pretty early on. But we often refer to them as intelligent designs. These are azoles that have taken all the things that went wrong with azoles and tried to make it better. So what they did is increase binding to CYP51, so they actually bind much better to fungi, which should increase lethality. They much lower binding to the mammalian CYP450 system, so they should make it less toxic and less drug-drug interactions. They have very long half-lives, greater than 6 days for all of them. They stay around for a very long time. They have good absorption and very predictable PK. So these should be the next generation of azoles, hopefully a very forgiving azole. The next compound we're going to talk about, again, in this like shotgun approach to antifungals, is going to be the inculcated amphotericin B, or MAT2203. A compound I'm personally very excited for because one of the things I often tell my residents is the biggest determinant of how well people do with many fungal infections is how much amphotericin we can shove into their body. And so inculcated amphotericin B uses this very cool technology of lipid particles, nanocrystals, which trap the drug and make it orally bioavailable. So the drug gets taken up through the usual chyle system and then dumped into our blood, where it still stays inside of the sheet and is protected until it is phagocytosed into a low, I believe it's a low pH and low calcium environment. But I would have to be corrected by the actual people who know this compound better than I do, which I'm guessing are on the call. And what's wonderful is that it's the antigen-presenting cells and phagocytosis cells that engage phagocytosis in humans and fungi that will actually eat this and then open up amphotericin inside of the body. And so they're delivered to the site of the target, which allows us to push the dose quite a bit higher so that we may actually be able to get much more amphotericin into people. The kidneys appear to be protected, which is always great because I am the #1 enemy of our nephrologists. And it doesn't appear to change the spectrum of activity. We're starting to get really early human data now. I'm really excited about the future of this compound. So the next part is big, and this is we're going to be talking about intracellular agents. But again, for the interest of time, we're going to be kind of ignoring a lot of these. Many of them are kind of early in their development, and some of them are not progressing at this rate, and some are going to be progressing in the future. So, but again, for the interest of time, we're really going to be only talking about Allurafin. The other ones, again, if you want to learn more about them, there is the review, and I would really strongly recommend. It's a really good primer. So if we talk about Allurafin, It is a DHODH inhibitor. So it inhibits DNA synthesis, and this is a very much an oversimplification. And John, please forgive me. I often tell my residents and fellows to think of this as think of it as a fungal bacterium, right? So that's kind of how I think of it. It inhibits DNA synthesis. The binding against the mammalian analog is much lower, so it really doesn't have any activity. It's orally bioavailable. It has wide tissue distribution, including the brain and synovium, and has orphan drug status against things like Lamentospora. And it's become the drug that through a trial I've been using a lot for salvage. It has very good activity against hyaline hyphomycetes, dematiaceous molds, dimorphic molds. It's active against highly resistant strains, so things like Scedosporium, Lamentospora, Scipular Epsibrumtii. And it has no activity against yeast and mucorales, which is actually kind of nice from our standpoint, because if you have, if you had a pan antifungal, it may become the most overindulged drug by the BMT service. Resistance appears to be really hard to induce. Hepatotoxicity signal is comparable to azole, so it does have that kind of a signal. It's currently in an open label salvage trial for susceptible molds. Phase 3 trial for Aspergillus is starting soon. Possible clinical roles for things like pan-resistant molds, Aspergillus, dimorphics. I think we're going to see a lot more to come from this compound in the near future. So this is my summary, and with this slide, I will kind of stop talking like an auctioneer. So currently there are limited options for many fungal infections, but what's really amazing at this moment in time is that there is now a salvage option for every single patient. So what that means is if you have a patient who's completely failing, or a patient who has a pan-resistant mold, you actually do have, at least through a clinical trial, a salvage option for them. Whereas in the past, for a lot of these, things like Lamentospora and some of the other ones, we would see the patient would say, well, call palliative. So I'm hoping that that is the future change that we see in mycology. And so with that, I will stop.
Thank you for the nice review, Andre. We'll start out with a couple of questions that came through while you were talking, and then I have one specifically for you. One of the questions was the ibrexafungerp plan moving forward. First of all, it's really tempting when you have patients with refractory Candida, stomatitis, or esophagitis due to resistant organisms not to prescribe this agent when they failed other agents. I think we've been challenged with that on a couple of occasions. Mm-hmm. Thankfully, we've been able to get them on the Fury study, and, right. and that's been a nice kind of way to get them enrolled. But a question came up about a candidemia trial, and I just responded by saying that there is a candidemia trial that has been designed. There are probably a few little wrinkles that need to be ironed mm-hmm. out, but that trial is designed to, or is designed with the intention of moving patients who receive Ibrexa over to oral therapy very quickly. Do you want to say anything about that?
Yeah, so I think that's going to be, it's a nice trial, because the idea is very pragmatic, right? Because it's the role that it's probably going to fill is going to be that transition to oral. So it's going to be, I think, in the very near future, starting to enroll.
First quarter is what we've been told.
Yeah, that's kind of what I've heard. And the idea will be to, very early transition as soon as the PIs start to feel comfortable, even as early as day 3, to transition from IV echinocandins to a randomized fluke versus ibrexafungerp, assuming that they're susceptible, right? Because you're not going to be transitioning to fluke if they're fluke resistant.
Well, I mean, we'll hear a little bit more about this. Joe Vasquez is going to talk to us about, early or de-escalation types of trials. Right. So this kind of broadly falls under that category.
Yeah, and I think what I wanted to say early on, but I didn't, is that the LPAD process that John made a comment of is largely a big part of why we're seeing this antifungal renaissance. It is the thing that is allowing it to become more commercially viable, and so it's part of why we're going to be seeing this now.
Okay. Jay Aram, who works at Pfizer, has an organism-specific question, and I'm going to follow it up with another one. He says, it doesn't seem that any of the antifungal development really address the mucorales. Is that correct? And if so, why do you think that is?
Mucor has just historically been a difficult compound, or difficult organism. And I think, to quote our friends in surgery, for mucor, nothing can heal like cold hard steel. And for mucor, one of the most important things always has been surgery. But there are compounds that do actually have mucorales activity, the azoles, the amphotericin, the oral amphotericin, presumably should have activity. So we will be seeing some of it. Hopefully soon, so the issue has always been very difficult research field. It's very hard to enroll enough mucor to get a clinical approval for mucor.
All right. Well, the follow-up to that, another organism-specific question is, as I've looked at these compounds, I've not seen anything that just really blows me away with its fusarium activity. Now, I know there are a couple of organisms, or a couple of the species that Allurafin picks up, but what have you seen as it relates to fusarium? Because we talk about, the big three, fusarium's really always in there. So.
Yeah, fusarium is a difficult one. The compound that I think is interesting for Allurafin does have very mixed activity. And if you get a good MIC, you'll do okay. I think we actually did have a fusarium into the trial in Allurafin. However, the compound that appears to be getting some of the more play with fusarium has been fosmanogepix. And they published, I think, in ECMID last year, kind of a salvage from their EIND with about 70% success rate with refractory fusarium. So that's partially, that number sounds really great to begin with, but it's refractory and it's EIND. So a decent amount of people died by the time they got to that stage. And so then maybe you're selecting a little bit more of a safer group, but it does have very good activity against fusarium. And so I'm hoping that is a venue where fusarium gets better coverage.
Yeah, we remember that voriconazole got approval for fusarium on the basis of about a success rate. If I'm not misquoting, it was like success in 7 out of 13 patients.
Right.
It was these are very difficult. Neil Stone asked this question, great summary. And he wants to know, are there any available published phase 2 data on Allurafin? Hard to convince my hemonc colleagues to get on board with a phase 3 without first seeing the details of that. I know there are phase 2 data, have we
that might actually be a much better question for John. But I will say that the phase 2, the single arm phase 2 is going well, and it's about 3/4 enrolled right now. And there's some obscene number of patient years of experience at this point for toxicity. And so toxicity data looks pretty good. The difficulty is always, individual numbers, but anecdotally, we're seeing really good responses. And but I will yield my time to John.
John, would you care to speak to the phase 2 data and where it's at, and what kind of patient, when it'll be published?
So I don't want this to be an Allurafin infomercial. Let me just remind you, Allurafin has breakthrough therapy designation from the FDA twice. We got it initially for invasive molds, and then we got it again for CNS cocci. And you can infer, this based on preliminary clinical data, that it did something that nothing else was doing. And we've not yet shown the data from the ongoing phase 2 trial, because it's an ongoing phase 2 trial, and we're trying to get to the end of it before we put it out there. Because if we release the data, then we're going to start to influence study conduct. Who you choose to enroll, why you keep somebody in a trial might be changed by the fact that we release the data. We've put a few case reports out. And I say breakthrough therapy designation, you can get the wording of it off of our website. So let me just stop there and say it's a slippery slope when you start to disclose data from an ongoing trial. And that's the essential point.
Okay. All right. Thank you. Thank you, John. Okay. Are there any other questions? Because if not, this is a good break time, and we may have found ourselves 5 extra minutes here. So Andre, I would like to thank you for presenting that. I think that you've really, you and your group have distinguished yourself for putting together what I think is really the best review of the new antifungal agents out there. It's very complete. It even includes Aereo Basidium and a lot of other agents that may or may not see the light of day, but still it's very complete, gives really good timelines. That graph is something that I like to use in talks that I give on this topic. So
it's a funny story, because Paul Sachs invited me to write it based off of a tweet, and then when we wrote it, I sent him an email saying, "Hey, it's 9,500 words. Do you want this to be 2 or 3?" And he said, "No, we'll just do it all as one big one."
Well, it's encyclopedic.
It's encyclopedic, yeah.
All right. Well, Andre, thank you. Thank the other speakers that we've had thus far.